Hi, this is your recording for Perfusion Part 1. Our exemplars are myocardial infarction and acute coronary syndrome, which is 16C in your book. So what you need to do, we got to do a little review, talk about a few things. There's sub-concepts. So I would highly recommend that you pull out your concept analysis diagram for perfusion because I've made some changes to that, specifically to this sub-concept area. What your diagram uses is volume, vascular tone, and pump performance. So that is correct, but the terms we really hear that might be somewhat familiar to you because of pharmacology is preload, afterload, and contractility. So I've added those on there for you. We're going to talk about it a little bit here, specifically focusing on contractility. And then in the next module, when we do perfusion part 2, we're really going to get down to exactly how to measure preload and afterload and contractility, which are those values that you see on there. So what I want you to do is be sure and review your A&P, get your blood flow through the heart down, because you're going to need that for this. You're going to need it for dysrhythmias. You need it certainly for congenital heart defects, so get that down. Look at your principles of perfusion, your assessment and care of patients with coronary artery disease and angina or angina, however you like to say it, because you've already had that. The other thing I want you to look at is diet and exercise. So I did in your notes, because you should have your outline open, you've got the Life Essential 8 from the American Heart Association, which is 8 important pieces, 8 important factors that we need to work on for cardiovascular health. So I don't know if you've seen that before, but that's important. You also need to look at the heart healthy diet, because it is just not a low-fat, low-cholesterol diet, low-sodium diet. There's much more to that. So you do have hyperlinks to those, so that's important. Look at the pharmacology table 16.1 and review those. We'll talk about it, but you've had pharmacology. We need to look at that. And then some basic diagnostic tests for coronary artery disease. Because you've had all that background, and what we're going to do is we're going to focus on the acute MI and actually what's called acute coronary syndrome. So let's start with patho. I will tell you, you can follow along in your book, but I found your book because it's already talked about everything, and then it's like, oh, let's talk about acute coronary syndrome. Let's talk over here about MI. And it didn't give some specifics that are important. So I found it a little difficult to read. So what I have done is I've compiled these notes in a way that's going to help it make way much more sense to you. So let's start with the patho of really acute coronary syndrome. That's the overall term. If you like the old outline where you do the big Roman numeral 1, that is acute coronary syndrome, or ACS. So we have coronary risk factors. Then we have endothelial injury. They develop a fatty streak, and then we get inflammation of the intimal lining of the artery. That plaque buildup is called coronary artery disease, or atherosclerosis. Now, what happens in acute coronary syndrome is that plaque is going to rupture, and you can see it in this middle picture, and we get platelet aggregation because your body's like, oh my God, I'm bleeding to death, so it sends platelets there, and we get a clot, and we have compromised blood flow to the heart itself. This is the coronary arteries on top of the heart that feed the heart itself. And that is what acute coronary syndrome is. So there's a couple of links for you to look at for some YouTube videos that explain this. I know it's kind of old, but there's just not a better one out there. Plus, I really do try to look for things that are not really long. Okay, so that's the background. That should really not be things that you haven't heard and understand. All right, so let's get to what this acute coronary syndrome is. So, like I said, acute coronary syndrome is that Roman numeral 1 with lots of things underneath it. So what is underneath it? Unstable angina, non-STEMI, and STEMI. Okay, so I'm going to explain what those are. You should already understand angina. Angina occurs when we have more demand than supply, more demand from our heart than the oxygen supply to the heart itself than the heart can give us. So we have a supply and demand issue. We have stable angina and we have unstable angina. So you should have already learned about stable and unstable angina. So stable angina, it's very predictable. It occurs with exertion, relieved with rest. They may take nitroglycerins. They could be on beta blockers, could be on calcium channel blockers. Okay, no big deal. We don't see them in the hospital. They don't come in for stable angina. Now, I may admit somebody for hip surgery who has unstable or has stable angina or a history of CAD. Great. I just need to put that in the back of my mind to know that they have a cardiac history. But what we're going to talk about is unstable angina. And unstable angina is ischemia to the cardiac tissues, but I haven't killed any heart cells. It's unpredictable. It's more severe. It occurs at rest. It requires more use of nitrates. What we see on the EKG is we see ST segment depression and or T-wave inversion. And we're going to look at an EKG in just a minute. You got to get what? EKG back in your brain so that you understand this. So unstable angina, I have signs of ischemia, not enough oxygen to the heart on my EKG, ST segment depression, and or flipped or inverted T waves. I tend to say flipped T waves. But their troponin, that lab work that's cardiac specific, is normal because we haven't killed heart cells yet. That's unstable angina. That is under acute coronary syndrome. Now, the two things that are left are non-STEMI and STEMI. These are both heart attacks. I got dead coronary cells. Your book doesn't differentiate between the two, but you're going to hear about it all the time in clinical, so I think it's important that you understand what this is. So let's start with STEMI because this is easier. STEMI stands for ST elevation myocardial infarction. So I have ST elevation and my troponin's elevated. So ST elevation, emergency, emergency. My patient's they're having injury and trying to have a heart attack right now, and my patient's going to be dead and have dead cardiac cells and or be dead if I don't do something. That is STEMI. They're having a heart attack right now. A non-STEMI is non-ST elevated myocardial infarction. One of my favorite questions to ask students in clinical is they say, oh, I've got a patient who's had a non-STEMI. Or in-STEMI, it's however you want to say. I say non-STEMI, some people just say in-STEMI, and I always say, have they had a heart attack? And sometimes y'all look at me and go, no. And I'm like, well, the last two letters are MI, which means myocardial infarction. So this is a heart attack. What it is not is ST elevation. So what they have is ST segment depression and or flipped T waves, but their troponin comes back positive. Okay, so let's look at this, because with unstable angina, I have ST segment depression, T-wave inversion. Non-STEMI, ST segment depression, T-wave inversion. The thing that's the difference, unstable angina, they have not killed any heart cells. Their troponin's normal. Non-STEMI, troponin's elevated, which means I have some dead cardiac cells. That's the difference between unstable angina and non-STEMI. STEMI, ST elevation MI, having a heart attack right now. I have ST elevation and a positive troponin. So be sure you take some notes on this. Look this over. This tends to be confusing so that you can get these straight. I will say patients are admitted with acute coronary syndrome. Sometimes they're admitted with a STEMI. Sometimes it says non-STEMI. We may see all of those terms. All right, so let's look at this EKG that we've been talking about. So this is a regular normal EKG. You have a PQRST, PQRST, and this is the isoelectric line. This is where that ST segment should be at the isoelectric line. If I have ST segment depression, that is ischemia, or the cardiac cells are not getting enough oxygen. Could be a flip T wave. That's ischemia. ST segment elevation, myocardial injury. This is having a heart attack right now. My patient's having dead heart cells and could be dead if I don't do anything. So the way you remember this is think about if you've seen firemen in their dress uniforms, and specifically I think we see it more on the East Coast, they wear their hats. Actually, they wear their hats when they go out on duty. And this is the front where the shield is, and this is the part that goes over their head. So I have ST elevation. Rear, emergency, emergency. My patient's having a heart attack right now. They've got cardiac cells that are dying. My patient might die if I don't do anything. So that's injury. That's an active state. A myocardial infarction is a Q wave, and a Q wave goes down. It has to be at least one box wide, and it is a quarter to a third the size of the R wave. And that means they've had a myocardial infarction, and that is old and happened in the past. The two I'm most concerned about is ischemia and injury. So I call these the I words, so be sure you understand these I words. All right, I'm going to stop our recording here, and we're going to come back and talk about risk factors, clinical manifestations, our diagnostic tests, and all of those things.